Hello, and thank you for joining today's Addictions Research Meets Lived Experience Lessons Learned, Opportunities, and Challenges webinar. At this time, all participants are in a listen-only mode. You may submit questions at any time throughout the webinar via the Q&A function on your screen. Questions will be answered as time permits. This call is being recorded for note-taking purposes only. And it is now my pleasure to turn the call over to Kelly Barth. Please go ahead.
Thank you. Welcome, everyone, and thank you for joining us today. I'm Kelly Barth from the Medical University of South Carolina, and I serve on CTN's Southern Consortium node. I'll be getting us started today with a brief overview of our webinar. As we all know, peer support specialists have expanded to a wide variety of healthcare service areas, and evaluating the impact of peer services is an important addition to research, both inside and outside the CTN. In our webinar today, we will come together to hear from presenters and panel members who will share their experiences in conducting clinical trials involving people with lived experience with substance use disorders, or peer support specialists, as an integral component of their study intervention. The goal of this webinar is to assist investigators in designing future studies involving peer support specialists as interventionists. So I'll briefly review the agenda. So the agenda for today will include an overview of the development of peer services in addiction treatment by Dr. Humphreys, followed by a brief description of 3 research projects involving peer support specialists. And then we will conclude with a panel discussion of relevant topics in this area. Now I'd like to introduce our first speaker. We are honored to have Dr. Keith Humphreys present to us today. Dr. Humphreys is an HSR&D Senior Research Career Scientist at Palo Alto VA Healthcare System. He is also the Esther Ting Memorial Professor in the Department of Psychiatry at Stanford and NPI with Dr. Todd Korthuis of the Western States node of the CTN. Dr. Humphreys' talk is entitled A Primer on Peer Helpers and Addiction. Thank you, Dr. Humphreys, for starting us off today.
Thank you very much, Dr. Barth, and thanks everybody for your interest in this topic. So I'm just going to take 15 minutes to tell you how we got there, or got here rather, excuse me. So for starters, let's see if I can get this to work. Okay, there we go. So if you've ever wondered with envy why other specialties like geriatrics, pediatrics, oncology, and cardiology are so well integrated into American healthcare, but we aren't, it's because they were born in the house of medicine. They were created by doctors in hospitals. So they had a head start on us on becoming a part of how this country takes care of people who are sick. And we have a different history. We basically have 3 parents that created addiction treatment in the United States. One is the criminal justice system. You may know the first 2 big treatment programs at Fort Worth and Lexington were actually run by the Federal Bureau of Prisons. And that history is still with us today. There was the social welfare system. That'd be like Salvation Army, which takes care of destitute people in some of the toughest neighborhoods in this country, very nobly so. And that inevitably means that they encountered addiction in their work. And then there are the mutual help fellowships. So these are the organizations that you all know that embody the peer help spirit. Interesting thing, if you look around the world, is every country seems to have these peer help organizations for addiction. They have different origins. Some were based in religions. Some were based in the labor movement. Some were based in started as alumni association of treatment agencies. Some were offshoots or modifications of the American invention, Alcoholics Anonymous. But they exist everywhere, and I think that tells you something about no matter where people are, there is some sense that if I have an addiction, I want to engage with other people who have been through the same thing. There's some level of cohesion, trust, and connection that comes from that. Not that professional services aren't good. Of course they're good, but there is also this human element of peer-to-peer connection that people value. If you want to read more about these, I wrote a book about them a long time ago. You can probably find for about $5 online, unless it's an autograph copy. Those are always cheaper. Okay, so the most famous one of these groups is Alcoholics Anonymous. It was founded in Akron, Ohio, in 1935, and by two men, and they said their sole purpose was to help alcoholics become sober. Now, I have alcoholics in quotes because we don't say alcoholic in care. We would say someone with a serious alcohol use disorder, but this is the language they use to refer to themselves. And their goal was sobriety. Sobriety meaning not just not drinking anymore, but also changing one's life, one's relationships, one's spiritual outlook into to become a productive, healthy person with a sense of serenity about living. AA offers meetings. That's where peers gather together. It offers sponsorship. That's where a more experienced peer will mentor a less experienced person through the process. And they have lots of literature and books that sort of explain their way of looking at the world. It works on a disease model, again, putting that in quotes because they wouldn't mean that the way I might if I were in Stanford Hospital or the VA hospital, but more in a sense of disease, discomfort, basic character, basic spiritual discomfort as seen as the root of addiction. It's an incredibly successful organization. Clearly, they were meeting a need that no one else was. I remember in the 30s, doctors were throwing patients with alcohol problems out of hospitals. Nobody wanted to take care of people with addictions, and they innovated and provided a resource that did. So 2 people in 1935, 50,000 people by 1950. Today, probably about 5 million worldwide in over 190 countries. And they profoundly affected the field, in part because they were the first people to actually care about the people we all focus our careers on. And they also provided a lot of the person power for the early development of drug counseling. So if you read Bill White's histories of that, it's really kind of astonishing. These were jobs that started to appear in the 60s, 70s, and 80s, not very well paid jobs. And a large number of people took those jobs, giving up higher paid, more prestigious professions because of their deep commitment to helping people with substance use disorder, helping their peers, because they themselves were in recovery. And a lot of those people were in the various 12-step fellowships. For a long time, we weren't really sure if these actually worked, and we knew they were popular, but we got pretty good evidence on this now. I'd say very good. There were always correlational studies, but those are subject to selection bias. But this study was a real landmark. This was led by my colleague and friend, Chris Timko. This was with people with all sorts of addictions, alcohol, opioids, cocaine, what have you, who were being treated in an outpatient facility that I happen to work in, the VA in Menlo Park. And she found a way to get a randomized design out of this. And what it was half the people were randomized to get the usual care for referring people to groups, which is basically, here's a brochure. There are groups out there if you might want to take a look at them if you wish. The other one was a structured introduction where somebody spent a half hour with the person, explained to them what groups are, what kinds there were, dealt with any anxieties they had, and introduced them to an experienced member who would take them to their first meeting. Pretty small intervention, but very big effects. Using the addiction severity index with high follow-up rates, Chris and her team found that there was 60% greater improvement in outcomes in those who got that warm handoff into AA, NA, and other 12-step groups. And as I said, this was a randomized design, so it was quite important for showing, these groups actually seem to work. In other words, peers actually do have particular power. We followed up on this in a lot of other studies. This was led by John Kelly, and was also collaborating with Marika Ferry, and pulling together all the various rigorous studies that have been done of AA in the Cochrane collaboration process. If you know this process, it is the most Teutonic review imaginable. Even before you review the literature, your method of reviewing has to be rigorously reviewed. It takes years, a lot of work, and I give John great credit for taking most of the weight on doing this. What it found, looking around the world, we found 27 primary studies enrolling over 10,000 people, almost all of them clinical trials or quasi-clinical trials. We had a few that were pretty rigorous quasi-experiments and some economic studies. But basically, these are studies that had pretty strong validity, and we wanted to see what is the sort of international judgment about whether or not this peer help organization, Alcoholics Anonymous, actually helps people. And the effects were pretty strong. The alcohol outcomes, we can divide into 2 groups. For pure abstinence measures, whatever those are, like months of abstinence, consecutive days of abstinence, 12-step facilitation and AA both significantly outperformed other very good therapies, the kinds I was trained in, maybe you were trained in, like CBT and MAT. For other alcohol-related outcomes like drinks per drinking day and alcohol-related consequences, AA was surprisingly perhaps just as good as those other therapies. So yes, it promotes abstinence extremely well, but it also produced other positive outcomes. The review also concluded that it reduced healthcare costs pretty significantly. When people get involved in these groups, their health gets better, they go to the doctor less, perhaps because they're getting a lot of their kinds of needs like, attention, caring, pat on the back, friendship that they might seek in the healthcare system. They instead seek from the mutual health programs. And that's how they're able to use less healthcare, but maintain very good health. There's other effects you can see of these groups in the literature: reduced depression, less anxiety, a greater sense that life has meaning, and stronger intimate relationships. That means both in terms of marriage, but also even if you ask about quality of friendship, it seems to improve as people participate in these peer groups. None of this should really surprise us. There is a sort of snobbishness sometimes in the field professionals have towards 12-step groups because they aren't professional and all that. But if I told you I was going to try to start jogging and I joined a group of other joggers and we all jogged together and it was fun, and you would think, oh, he's more likely to stick with it. Or if I said I was going to, lose 10 pounds and I was hanging out with a bunch of people and we were all trying to lose 10 pounds together and we exercised the diets, you would think I'd have a better chance. Or for that matter, if I was trying to learn a foreign language and I set up a group at work where we chat in the language at lunch, you would say, oh, you're more likely to get it. Because social support, modeling, practical advice make it easier to change health behavior. Well, we all know that. It's also true of behavior with substance use, and I think AA and the other fellowships demonstrate that. Now, peer helping is a much broader concept than 12-step. It is not just 12-step, but it is taking the idea that someone who has been there has something special to offer. And, we don't need to reinvent the 12-step fellowships because we already have them. In the healthcare system, we can refer people to them. But peer helpers are brought into the healthcare system in new ways. They can support people in recovery. It is very important that peer helpers recognize their job is not to make the person recover exactly the way I did, but instead to support many pathways to recovery. So maybe I got better through methadone and counseling, but the way you're going to get better is going to a rehab or going to NA or getting cognitive behavioral counseling or something else. But my goal as a peer is to just help you on whatever your path is, not necessarily what my path is. 12-step involvement is not required at all for peer helpers, nor is it the measure of its effectiveness. The measure of its effectiveness is, does the person get better? Is their health better? Are they using less substances? Or is their life coming together? If they don't need 12-step to do that, well, that's just fine. As we see greater and greater integration, it's a pretty exciting time. You're interested in peer help. The VA in which I work now has over 1,000 peer helpers as a core part of our mental health and substance use services throughout the United States. Certain states are now covering peer help, peer counseling, recovery coaching through the Medicaid program. And the block grant program, which is you may know is the federal grant program to states, now has a bit set aside for recovery support services in which peer help fits rather nicely. So it's an exciting time. But all that means, of course, is, we're doing more and more of it. It's pretty exciting, but we always have to ask, does it work? It looks good, it sounds good, but still we need to do rigorous science. And so I'm going to turn now this panel over to some really top-notch scientists who are going to tell you how they're answering that very important question. Thank you.
Okay, thank you, Dr. Humphreys. I'll be the first presenter on the list of presenters of scientists working with peers in research. So I'll share my slides. Yeah. Okay, so our trial is a CTN trial. It's called Peer Intervention to Link Overdose Survivors to Treatment, or PILOT. Back in 2015, inspired by Gail D'Onofrio's work, we were initiating buprenorphine in our emergency departments for patients with opioid use disorder And overall, it was going really well. But we kept hearing from our colleagues and clinicians that working with patients presenting after an overdose was different and possibly more challenging. First of all, many of the overdose survivors had just experienced precipitated withdrawal, and therefore, understandably, many weren't ready for starting treatment right at that moment. Also, a substantial portion of the patients did not see themselves as having an opioid use disorder. However, this population was walking out without treatment and remained at high risk for overdose in the next month to year. So around the same time, we were introduced to the work of Rich Jones, who was a peer support specialist at the time and CEO of the Faces and Voices of Recovery of Greenville, South Carolina, which is it's also abbreviated FAVOR, and it's a community-based recovery organization. Rich and his team of peers were doing really innovative work in both inpatient units and in the emergency department, specifically with peers going into the hospitals and the emergency departments and working with patients with addiction, including overdose survivors. But Rich's team, using a technique called assertive engagement, which is a different type of approach than traditional 12-step approach, the peers take responsibility for reaching out and maintaining contact with the individual with substance use disorder, regardless of their readiness for treatment. So this seemed like a good match for the overdose population. So with Rich Jones's promising preliminary work, we worked with him to develop the pilot intervention, which is a manualized adaptation of FAVOR Greenville's peer ED overdose program. So right from the beginning, the study really served as a vehicle for peers to conduct a research study. So together with Rich and Tricia Laudel, who was another FAVOR Greenville peer and leader in that area, we developed an intervention where peer support specialists trained in overdose meet with overdose survivors in the emergency department, ideally, and then follow them in the community for 6 months. So Rich and Tricia became part of our study team right from the beginning, and through intervention and protocol development, we all worked together to distill the intervention into 3 key components. Assertive engagement, which we discussed, utilizing a participant-directed approach. So that utilizes the spirit of motivational interviewing to meet patients where they're at, respecting all pathways to recovery and incorporating harm reduction, and then active supervision. So we acknowledge that this patient population is a very high-risk group for overdose. Many have ongoing active use, so regular peer supervision is support for the peers is key. The primary aim of our study is to compare the effectiveness of the 6-month pilot intervention versus treatment as usual in 150 individuals admitted to the emergency department after an overdose involving opioids on the primary outcome measure of overdose risk behavior frequency at 6 months. So we measure that at baseline and then measure that intermittently, including at 6 months. We have 3 sites. Mercy Health in Youngstown, Ohio, where our peers are Crecia London, Shardina Dixon-Wilson, and Anthony Dawson. Providence Everett in Everett, Washington, where Curtis Letskis, Barbara Lewis are the peer support specialists. And Prisma Health in Greenville, South Carolina, where Tricia Laudel, Crystal Fowler, and Joey Klotz were peers. As far as integration of the peers into our research activities, you can see here that Rich and Tricia have been integrally involved with the entire study from the beginning, including study design, intervention development, national training. All of our peers on the trial have to be trained on the intervention, and to this day with weekly supervision, study decisions, and dissemination. Rich and Tricia are also involved with our weekly national peer supervision you can see here. So in this trial, each site has a lead peer who provides local supervision, and then everyone joins in virtual and national supervision every week. So Tim Matheson and Louise Haynes organize and lead these calls, but we know that it's very important to have peers involved with peer supervision. So Rich and Tricia fill that role as well. And it's just a delightful and talented group of peers who just do great work. Lastly, as far as cross-training and dissemination with the pilot peers, both Curtis Letskis, up here on the left, and Shardina Dixon-Wilson here, participated in the CTN steering committee meeting, and Shardina presented on a panel, which was a great experience. We also presented a poster at that meeting with several peers as co-authors, and we have 2 current manuscripts under review with peers as co-authors. And we plan to continue that with future dissemination efforts, with the goal for our team to have at least 1 peer on every manuscript or poster. And then lastly, as far as cross-training goes, both Anthony Dawson here on the bottom left and Shardina Dixon at Mercy have cross-trained as research coordinators with training from their CTN node staff. So they were able to fill in when another research assistant was out on parental leave. And then Curtis at Providence has also served in an outreach role to help with recruitment. So we provided training, both us and the nodes, on in both circumstances of how to delineate the role of peer versus RA and how you can't serve as both for any given participant. So overall, I think that went really well and gave us a lot of flexibility for a smaller trial. And with that, I will end here and give a big thanks to all of our pilot peers. Thank you.
Hey, thanks, Kelly. I think I'm up next. Hold on 1 second here while I pull up my slides. Okay. I've been invited to this webinar because I am the co-chair with Nabila El-Bassel on the Integrated Strategies Protocol for HB 10094, INTEGRA, a Vanguard study of a mobile health delivery that link persons who inject drugs to integrated care and prevention of addiction, HIV, HCV, and primary care. So we started this study wanting to test whether providing care in a medical mobile unit for people who are out of opioids use disorder treatment and at risk for HIV or living with HIV would benefit from receiving that care when it's taken to them, that whole person care taken to them, as opposed to going to bricks and mortar facilities. We have 5 US cities where this study is being tested, but what we first came up to something really that stopped us, and Dr. Humphreys alluded to this, that there is no standard of care for people who are out of treatment and living at risk for HIV or living with HIV in this country. So we had to provide the peer navigation for the support for the study, and then test whether providing the peer navigation alone versus providing the peer navigation and the services delivered in the medical unit would provide a significant difference, sort of testing directly the efficacy of the mobile medical unit strategy. So we developed, Nabila El-Bassel and I built this model. It was largely, Nabila is a social worker, so it's largely based on her experience, and the peer navigation was used to integrate the interventions on the intersection epidemics of addiction and infectious diseases and to provide links to other needed services. In the study that I described, both arms use navigation, peer navigation, to engage, link, and retain people who inject drugs in opioid treatment, a medication, and harm reduction, HIV care, medications, and PrEP, primary care, testing and treatment for sexually transmitted infections and HCV, and mental health diagnosis and treatment, referral to treatment, trauma services, social services, housing, et cetera. And I really want to underscore that there is no standard of care for people who inject drugs in the US for access to any of these services, leave aside all of them. The peer model that we wrote integrates multiple theories, including systems theory, social determinants of health, structural vulnerability theory, and intersectionality. We draw on concepts of social support theory, social cognitive and social learning theories, and self-determination theory and empowerment theory. And you can see here's the GW van that we used on this, that'll be showing throughout this presentation. The guiding principles and approach for navigation in this approach is person-centered. That is, prioritizing the needs and the preferences of the participants. It's strengths-based. It's pulling from strengths and assets rather than a deficit model. Drawing on shared lived experience so that the peers can share experiences and provide practical advice. You've heard some of that already. And then cultural competence to deliver a culturally sensitive intervention that fosters a sense of connection and understanding, recognizing that addiction is not about a disease, it's about a lack of connection, and being able to treat in that regard, as Dr. Humphreys described. The guiding principles and approach, it's trauma informed. We have screening and assessment to identify trauma histories and the potential influence on substance use, mental health, and overall well-being. Attention is paid to the root causes of barriers to accessing care, particularly structural systemic racism. We see that in our participants, the lack of housing, incarceration, stigmatization by providers and systems. These are the major reasons why people remain out of care, even if one is interested in seeking care, that these are really strong barriers that people face when you're really down on your luck. Flexible intensity, we set it up so that there's no required dose of navigation. And in fact, we see that different sites use more doses of navigation or deliver more navigation. There's a wide variability across the participants enrolled. We have actually 410 people without HIV and 38 people with HIV in our complement of subjects. So we have a lot of variability there. And we treat people through the 26 weeks using the peer navigation approach. We learned that peer navigators on the front line burn out rapidly as you listen to all those things that I talked about, and peer navigator supervision and ongoing training provided by Al Hassan has been really integral into pulling the navigators together and helping them to do the work so well. So we're using 094 is using implementation science to understand barriers and facilitators that affect integrated peer navigation as it's implemented in different settings. And we learn how these contexts affects the intervention effectiveness and especially develop fidelity of the implementation. So this is the type of model we're using. We've got it described and written up. This is my colleague, Dr. El Bissell, who is my co-leader on this. And these are the references of the funded work. So I'll stop here.
Hi, everyone. I'll just go ahead and pull up my slides. All right, I'm Todd Korthuis from Oregon Health and Science University, part of the Western States node, along with Dr. Humphreys. I'll be talking about the Oregon Hope model, a peer recovery support specialist model for engaging people who use drugs in rural regions. And my colleague, Joanna Cooper, will be joining us for the panel. Oregon ranks among states with the highest reported illicit drug use, the lowest access to substance use disorder care, and our overdose rates, like much of the country, continue to surge. Despite this, there is very limited access to either harm reduction or treatment services in our rural communities, which often bear a disproportionate share of overdose rates. And what we found was that, as you've been hearing, peers are the trusted voices among people who use drugs who are not seeking care. And I would just challenge us to think about systems shifting of how we think.
Your slides are not showing. Can you pull those up, please?
Oh, gosh. So sorry. It looks like I'm sharing them. Let's see. Thank you for redirecting there. There we go. Okay.
There we go. Thank you.
Yeah. So I'll just pick up right where I am. So let's see. Can you see it in full screen view?
Yep, we're seeing the slide sorter on the right. So if you'll take us into presentation mode. And if not, I do have them ready and can pull them up as well.
There we go.
That looks great.
Change my view a little bit here. Oop. All right. So you're seeing a slide called Shifting Systems of Care.
And they came down again, Todd. I'm going to bring those up, and if you'll just cue me for next slide, I can advance them for you.
Okay. There we go. So I would challenge us to think about shifting our systems of care. As you heard from the pilot study and some of the background, we're starting to do a great job of integrating peer recovery support specialists into healthcare system settings, where people who use drugs land typically as a last resort. Next slide. When in reality, most people who use drugs are outside of the healthcare system for the reasons you heard from Dr. Shoptaw, and a lot of the stigma that they've experienced with the healthcare and behavioral treatment system in the past. Peers have the capacity to serve as a bridge and shift the systems of care from asking people to come to us to going to them. As you also heard from HPTN study. Next slide. And so we designed a peer intervention specifically initially targeted to our high needs rural counties called the Oregon Hope Peer Engagement Model. I'm talking about this model because it's been the basis for several other studies that have occurred, but it all started here. What we did was recruit local people with lived experience with drug use who had at least 2 years of recovery under their belt. We hired and supervised them through contracts with local community-based organizations. The peers were trained in community outreach and harm reduction techniques, as well as rapid Hep C and HIV testing. But their main job was to go out and make friends, build relationships with people in the communities that they knew. They conducted community outreach in parks and very diverse settings in the woods. We're a very rural state. They gave people harm reduction gift bags that included naloxone overdose kits, up to 30 syringe exchange fentanyl test strips when available. And they offered people rapid Hep C and HIV testing and linkage to substance use services, as well as many other services. Next slide. Okay. And we're getting ready to present the results of our first two our first two studies, an overdose prevention intervention and the peer-facilitated telehep C treatment intervention at Immersa this week. It's also served as a platform for other treatment trials, including recently funded peer-facilitated contingency management study for people using methamphetamine, and a brand new study where peers are screening for methamphetamine-associated heart failure. Next slide. So one of the things that we found was that even though peers were initially hired to do the peer work, they rapidly turned into research assistants. And I have to say, this has been a game changer for us as a research team. They completed human subject CD and GCP training. They vetted our survey items for communication and overall content. They ended up consenting participants, collecting data, including biospecimens with HIV, Hep C, and syphilis testing. They have achieved so far in our first two studies greater than 85% six-month study retention, and continue and inform our research questions and analysis. And like you heard from Dr. Barth, they're an integral part of our research team now, and included as co-authors on our publications. Next slide. Support is crucial. You've already heard about this, so I will skim through it. But we offered peers both clinical support with formal supervision, and supervision through weekly team meetings as well. And then as the peer network has expanded, this has turned into a monthly learning collaborative and twice-year statewide peer conferences. We support them in research skills through inclusion in our weekly ops meeting, and through frequent site visits and data QA. And this has been a real career development opportunity for many of our peers, some of whom this was their first job for a very, very long time. Others have moved on to leadership positions within the behavioral health treatment system. Next slide. And I'll stop here with really just a remarkable statewide expansion. The Oregon Health Authority looked at our preliminary data and have decided to expand the peer model to 24 of our 36 counties for engaging people who use drugs. And our Telehep C model has now been expanded at 18 counties funded through SAMHSA SOR funds. Next slide, and I think that's it. Peers work. They're the glue. Best thing since sliced bread. I'll stop there.
Excellent. Well, thank you, Doctors Korthuis, Shoptaw, and Barth, for your review of the exciting peer support interventions you're directing. It's really cool to hear of the engagement process and the retention process and how that is so well linked to utilizing peers and peer navigation. At this time, I'd like to introduce our panel members. We have Joanna Cooper. She's a peer coordinator, Oregon Health and Science University, working with Dr. Korthuis on the Hope Peer Engagement project. Pete Smith. He's a clinical research coordinator at the University of Pennsylvania, working on the HIV prevention network INTEGRA study with Dr. Shoptaw and his group. Louise Haynes. She's an assistant professor of psychiatry and behavioral sciences, Medical University of South Carolina, working with Dr. Barth on the pilot project. Todd Korthuis, professor of medicine, Oregon Health and Science University, working on a number of peer engagement processes or projects. The one he just mentioned here and presented was the Hope Peer Engagement project. And then Tim Matheson. Tim is the intervention director, counseling and interventionist supervisor with the San Francisco Department of Public Health. He too is working on the pilot project with Louise Haynes and Dr. Barth. So thank you all for agreeing to participate today, or being voluntold, so to speak. We've really looked to approach this webinar as a starting point for the discussion on how to best integrate and also to support peers within a research setting. And that's really what we're looking to do. And many of these projects have already progressed in that process, but we really wanted to share that progression with a wider group here. We opted really to focus on three aspects of our lessons learned. One was, getting started with peer involvement, and including how to engage them in developing the intervention and refining the intervention and some of the questions. Secondly, the implementation and how to actually implement a project such as this nature with so many moving parts, and then the challenges moving forward. Really what we want our panelists to do is describe what was done, and let the audience know if there were some things that maybe you'd do differently, if you had an opportunity to do that. So in terms of getting started, clinical trials have a lot of moving parts, most of which are fairly consistent across trials. However, the addition of peers within a research team really adds a different layer of complexity that many of us have not really encountered before, including hiring the individual, onboarding and training, orienting peers to work within a research setting, within, and adherence to a research protocol. And so first, I'd like to direct my first questions here to Pete and Joanna. And then, what advice would you provide when selecting a peer as part of a research team? And maybe, Pete, we'd go ahead and start with you on this one.
I would say, diversity is very important. And when I say diversity, I'm not just talking about, race, ethnicity, or gender. I mean, I'm also speaking about, because our study was a study specifically about opioid use disorder. So diversity in the different ways on how to, get control of your opioid use disorder. I think that's very important. I also believe that it's important to have peer navigators from the actual locale that you're trying to recruit from. Here in Philadelphia, the entire city has an opioid use disorder problem. However, it's different in South Philadelphia than it is in North Philadelphia. It's different in West Philadelphia than it is in Kensington. So, to have people that understand that from all different avenues, I think that's very important.
Excellent. Thank you, Pete. Joanne, anything to add to that in as it relates to sort of the onboarding process that you went through, or the hiring process that you went through?
Right. Yeah. Hi. So I think education is a big component of hiring a peer, and that we used a scoring board kind of to see how they were with the idea of like harm reduction, or being able to meet a client where they're at, like if they're judgmental. So I think that had a lot to do with our hiring process and just education as well.
Excellent. Thank you. So your scoring really sort of helped to determine maybe an individual's philosophy as it related to MOUD or to harm reduction as well. Nice.
Yeah, exactly.
Okay, excellent. Thank you. This next question really is directed towards the investigators, and including yourself, Louise. But I noticed that some of the projects were able to utilize peers in terms of developing the intervention, and I'd like to hear, Todd, you'd mentioned that as well. How did that enhance your project? I mean, and what would your recommendations along those lines be?
Well, for us, we were really, really fortunate in that the whole study sort of grew out of work that had been done by peers. So it wasn't so much a research-driven initiative as it was building on work that had already been done through a recovery organization, and then taking the work that they had done, which had not been manualized. There was not a manual of how they did it, and then trying to integrate that into more of a research model. But as we did that, trying to figure out how to do it, the leadership of the community organization were involved with us every step of the way. So they helped write the manual based on their work, and we ended up having to do that in an interesting way. We would have them come on calls with Tim and me, and they would talk us through this is what they did, and then we would write it down and give it back to them and say, does this accurately describe what you told us? So it was very much a iterative process back and forth. And then they were also involved in figuring out what did we need to do for the training of peers, and then ongoing supervision. So we definitely could not have done the project without their being involved every step of the way.
Excellent. Thank you. Todd?
Yeah, I would just reiterate the importance of really just partnering early on. We were so fortunate because in the first grant, we partnered directly with the Oregon Health Authority, who had a passionate peer advocate from the very beginning, who really understood this from her personal lived experience, and connected us with community-based organizations who would be supportive, and continues to sort of lead the charge, and was ultimately responsible for scale up to the rest of the state. So that was a real gift. And then I think the other thing was just frequent site visits. Oregon is very dispersed. Our farthest site was a 7-hour drive from Portland. And they have these counties are the size of Connecticut. And so site visits were crucial. And during the site visits, in addition to going on rounds with the peers in the community, we'd sit down and talk about next steps. We would go over the qualitative interview guides and get direct feedback on what was missing. And I showed some of the funded studies that have been grown out of this. They've all grown out of those conversations around pizza in the peer meetings.
I'm sorry I missed those meetings, but yeah, thank you. That communication, that feedback loop sounds like it was relevant and important to both of your projects. So let's talk a little bit about orienting and peers to working within research and also training, and I'm going to bounce this back to you, Pete, and Joanna. It's so important, when we talk about expectations of work, we talk about expectations of treatment and various things as we're working with patients. But the same thing holds true for staff who are working within a research setting. And I'm wondering how you went about orienting and training peers to work within your projects.
Well, as someone who kind of fell into the research field like 18 years ago, to me, it's kind of I don't think your average person really realizes how much research plays a part in their everyday life. So to sit and talk with someone and explain how, the data from research is what affects their laws, the data from research is what creates vaccines, and sit and have a conversation with someone and explain to him how the work that they're going to do is going to help shape the things that they want to have happen anyway. You kind of build that bond on, the goal is the same. Now we just need the data to show how do we get to that goal. And I think once you explain it on that basic level and everybody is on the same page, it's real easy for them to, embrace the research portion of a life they were already striving to live without the research component.
Excellent. Thank you, Pete. How about you, Joanna? You don't have the extensive history as Pete does. So this is probably a little bit, more familiar to you just in terms of how it impacted you, the training and the orientation.
Right. Yeah. So I was pretty fortunate that due to being a case manager at the HIV Alliance, I was good with the documentation part, so I could train the peers on how to handle that, and just hands-on training was really important for that. But in addition to like what Pete was saying or similar is that sitting down with the peers and educating them how important the work that we're doing now and how it's going to affect us in the future, and bring resources to a community that is really underserved. And I think that really had a big part into the enthusiasm of the peers on the research team.
Excellent. Thank you. I've always said that the peers that work on the HBTN project and of course across the other projects are really at the tip of the spear at really bringing life-saving, services to individuals who otherwise would not be seeking it. So thank you for that. And along those lines, Pete and Joanna, many of our peer support staff have navigated their own recovery from an abstinence-based perspective. And I'm wondering, how you were able to support and provide sort of education around MOUD and more widely embrace sort of a more harm reduction philosophy or approach over what might be, considered an abstinence-based approach. Joanna, why don't you go ahead and go first?
So as I was doing my internship at the HIV Alliance at the Needle Exchange, I sat in front of these people that were me 10 years ago, and just not being able to help them. So that really drove my force to harm reduction, because I thought to myself, how, if I had somebody to be there on a harm reduction level, instead of abstinent only telling me what to do. So that really helped me, like with my enthusiasm about harm reduction, portray it to the peers, the new hires, and also other community-based organizations that were just harm reduction or abstinence only. So yeah, that's kind of what I did. It was just like my passion of,
Nice. So you weren't just educating, the peers. You were educating the community as well while you're going through that process. Excellent.
Absolutely. Yep.
How about you, Pete?
It goes a little bit back to the diversity that I was speaking about earlier. I was lucky to have all four of my navigators had four separate modes of how they deal with their opioid use disorder. So I had a navigator who was abstinence based. I had a navigator who was methadone. I had a navigator who was Suboxone. So being able to sit in front of various people who have got to where you wanted to get to, but took a different mode, helps everybody to, not project what they may think is the right way, but be more accepting of there's a right way that may vary for everyone. Mm-hmm. So I think that allowed it to be, pretty easy for everyone who may not have been 100% harm reduction to realize how effective harm reduction was, even if it didn't play a part in their particular route to sobriety.
Excellent. That lived experience really played a huge role in that. Thank you. Appreciate that.
Al, if I could just jump in, quick question. Yes. About how the peer teams were integrated into the health force. If any of the panelists would like to speak to that. So Louise, maybe you can just
Sure.
Speak to that from your study.
Yeah. So yes, thinking about the importance of the peers for our study, the identification of the participants happened in the emergency department. So the importance of the peers getting to know people in the emergency department, getting to know the nurses, getting to know the people that work there. And initially, I think there was some hesitancy, about who are these people and what are they doing down here and how is this going to work? But then to the point that that the emergency department staff would ask, why isn't there a peer here now? So learning the importance of that. But it did take a good bit of work on the peers' part to put themselves out into a setting, a highly medicalized setting that they were not accustomed to, and over time, learning to sort of interact in that system. But I do think it's a challenge. It's a challenge of the work for sure.
Oh, great question. Thank you, Louise. So the next question is really directed to the researchers and the research team leads. But working within a protocol and the confines of a protocol can be difficult, even for some of the most experienced researchers. Let alone sort of naive clinical staff and peers when it comes to research. And so Todd, Louise, how are you able to ensure that your teams really had an adequate understanding of the questions, the research question you were trying to answer, how you were going to go about answering that, and then lastly, adherence to the protocol and how you were able to monitor fidelity to the protocol?
Todd, why don't you take that one first?
Sure. Yeah, training, and more training and retraining was the bedrock. This was for most of the peers involved, their first foray into research. We started with the very basics of research ethics and privacy, confidentiality, these sorts of things, and then built from there. And then during frequent site visits, we would do like we would in any study, review consent forms. And then the other key thing that I think helped a lot was we didn't view them as separate from, they were part of the research team, right? So they were involved in all of the operations meetings, and we talked through issues as they came up, and we tried to communicate a culture of transparency that, almost giving awards for people who said what went wrong that week and had a documentation issue or whatever, and let's problem solve around this.
Thank you, Todd. Louise?
And yeah, for us, it was interesting trying to think about how do you measure fidelity in the type of intervention that we were using in the study. Tim and I have done other studies using navigators where there were structured sessions and there was content that was covered in sessions, and the sessions were recorded and we listened to the sessions and gave feedback. So how do you do that when your intervention is largely around texting, and maybe there's going to be a face-to-face interaction or maybe not? So how in the world do you measure fidelity for that sort of intervention? So we came up with some ways to try to do that. One was to make sure that we thought the peers understood the intervention. So our method for doing that was to have peers do a case presentation to the other peers at all the sites on a supervision call, using sort of a structured kind of a format that demonstrated how they did certain things with their participant, like how did you use MI, and have them talk through how did you discuss multiple pathways, that sort of thing, but very structured. And then Tim and I would rate those case presentations that the peers did. That was one way we tried to get at, are we sure the peers really understand what it is that we're asking them to do? But measuring fidelity had to be done in a very different way than we had ever done before.
Excellent. Thank you. We're going to shift gears a little bit and talk more about implementation. And we're going to look at like scope of practice, documentation, supervision, and then study termination procedures, but also, and I think one of the crucial things here is matters of safety. Looking at, ensuring that somebody is continuing to engage in the recovery, but also physical safety factors with being out into the community. And so first, I'm going to, Pete, the HPTN project has just a wide scope of work, from helping people get IDs and insurance to, helping them find housing and food, along with MOUD and PrEP and ART. How did you prepare navigators for such an extensive scope of work?
Oh, well, one of the things that we've, pardon me, one of the things that we did at over here at Penn is we did a lot of cross training, and it wasn't, a lot of the responsibilities weren't solely on the peer navigators. So I assume a lot of the responsibilities. Even our drivers were trained on certain things. We have, you know, road trips for the drivers to take people to go get their ID. So then they have to be trained in, certain confidentiality issues and stuff like that. So we never put a single burden on the peer navigator, but we shared it as a group. So it was a large scope of things, but it was never just one person's responsibility to make sure that this just happens.
Excellent. Thanks. That team approach. How about you, Joanna? I mean, you've talked about going out into encampments, and helping people move their home, literally. I mean, how did you prepare your navigators for that?
Well, much like Pete, we used like a team system. We were much like a family on the study team. And I probably would just like working with the clients and working with our peers like as a client. So I would have my peers just message me and let me know where they're going to be, like their estimated time. So that way, if we needed to send out some help, but we really just tried to double up as a pair in a team whenever we went out into the field like that.
Nice. That's good to hear. Shifting gears a little bit, documentation, and Dr. Shoptaw has always said, if it's not documented, it didn't happen, right? And so I'm wondering, Joanna, what did you do to sort of enhance that documentation process with the peers that you're working with?
So we would definitely, we had to document in multiple places, but just letting the peers know how important it was to document, because that's a motto at the HIV Alliance, is if you didn't document it, it didn't happen. So just really educating, hands-on training with the peers, that documentation, and making sure like, hey, did you document this person, just in a team effort? Yeah.
Okay. All right. Pete, anything to add to that?
No, she pretty much hit it spot on. But like we would set aside time at the end of the day to make sure that we tightened up the documentation. Working out in the field, it's easy for you to forget something that might have happened earlier, or someone else sees something that you didn't see. So we would have like a little collaboration at the end of the day just to make sure that we captured everything. I think one of the other things that helped is, because our division does a lot of different studies and will be in a lot of different meetings, just for them to see nurses and PI screw up in certain ways, let you know. You know what I mean? So we try as we can, but it's possible for anyone on any level to not document as adequately as you may want them to. So just, things like that, and just reiterating the importance, but, letting you know, like, okay, but we have to make sure we know how to do it.
Yeah.
Al, I want to add one of the things that we learned sort of midstream, because we started out, there's a lot of documentation for peers, a daily documentation, a lot of documentation. And originally it was Tim and I trying to go in, to the eClinical system and keep up with the CU's document. And that just didn't work very well. And so then we got the data system, the DSC, to start doing reports for us. And then the reports, then we could take back as feedback to the peers, so they could see, how were we doing with documentation. And those reports actually ended up being a great tool to help us and to just reiterate the importance of the documentation. But we learned that, a ways into the study.
Yeah, excellent.
Could I just
Sure.
intervene? Sorry, just a quick question. Maybe Todd and Louise and maybe Pete could speak to curriculums or intervention manual used, how structured were these in helping peers know what they were supposed to do and keeping within their wheelhouse. Can you speak to any of that?
I know we had a really good peer navigator manual that was provided to us by the HPTN, and it was great. Everything you needed was right there. But what we didn't want to do is make you feel like you had to be a robot and follow it from point A to B. So always reiterate it. You want to capture everything that's in there, but you want to do it in a conversational method so that you never want to be a robot sitting there across from someone, So knowing the navigation manual was very important. You want to cover everything in there, but you don't have to cover everything in the order that it's written in the manual. So,
thank you, Pete. Others? Todd?
We also developed a peer training manual. I'll see if I can post it in the chat. I'm not sure.
I would say for us, we wrote the manual, prior to starting the study, and then we revised the manual as we went through the study. But I think the manual was not was not used as much as I would have anticipated that it would be by the peers. I think often it was Tim and me going back to say, well, let's go back and see what we wrote in the manual. But I do not think that the peers used it on an ongoing basis. I think more the shaping of the intervention was more done through supervision than in there referring to the manual.
Excellent. Thank you all.
I would second that with us as well.
Thank you.
Yeah.
So just one last comment on, thank you all, but one last comment on documentation. It's one thing to document within the confines of a brick and mortar office.
Yeah.
It's a whole different thing to document when you're out in the field, when you're in Kensington Gardens or you're out in the forest in Oregon, in a rural part of Oregon. And so those are some things that really do need to be taken into consideration. In terms of having peers out in the field, I'm wondering, when we place peers out in the field, we're in some ways we may be jeopardizing their recovery, especially when they're viewing individuals who are actively using. And I'm wondering, sort of, Pete and Joanna, what you all did to sort of support one another and to enhance self-care as it relates to recovery related matters.
Sure, I can. Okay, I can speak on this. So we definitely established. Now I forgot what the question was. I'm sorry.
No, that's all right. I can repeat it. So when peers are out in the community, it could challenge their recovery, and I'm wondering what you did to support one another and to make sure that folks were looking to take care of themselves and you were helping to support self-care.
Right. Yeah. So during our clinical weekly supervisions, and in addition to the weekly team meetings with Todd and everybody, we went over those recovery aspects, making sure that everybody was safe. One thing when I was running supervision was to ask peers what they were doing for self-care, not only to make sure that they were actually doing something, because then I could gauge off their answers if they were actually doing steps for self-care, but to give other peers an idea of things that they could do for self-care as well. Mm-hmm. And then we are much like a family, so we have a big group text, and anybody can call or text at any time, and somebody's going to be there to support one another as we continue on with this work.
Thank you, Joanna. Pete?
Well, one thing I could say, I feel like the attention to self-care came pretty good from up top, which makes it very easy to, you know, push it on our level. And that's coming from all the way from the HPTN. I mean, I a million meetings. That's kind of like the first thing I would always hear, and I'm not complaining, but it's like I'm just saying that's the first everything. So it's like when it comes from the top and it's reiterated all the time, it's really easy to let for everybody to feel that that's a priority. So on our level, like Joanna said, we have a lot of we group text all the time. We even set up for the sites because we're a 5 city site for all the sites to meet on a monthly basis, the peer navigators themselves, so that they could talk amongst themselves. But we also tried to establish some real time communication between the peer navigators from each site to, hey, is this going on in Philadelphia? Because this is what's happening in Los Angeles. Like things like this, just so that things don't seem just specific to you. Like, okay, someone else is going through this, and this is how we're handling it here. Try this. So it definitely helped that all the way up the top, all the way down, everybody's emphasis was self care, self care.
Yeah, thanks, Pete. And this follow up is really about safety in the community. Some of the communities that we go into can be pretty dangerous, and I'm wondering how you ensured safety, when your navigators were out in the community. I'll address that to you first, Pete. There you go.
Well, we nothing ever happens in the community solo. So it's rarely even just two people together in the community. It's normally either both peer navigators, a peer navigator, myself, and a driver. Like it's rarely two alone. But also just because of the our presence in the community for so long and us instilling our presence and communicating with the community what we're doing, we're kind of a fixture in the communities that we're in. So there's been instances where, someone may have gotten a little funky with us, and the drug dealer across the street has come across the street and kicked them out of it. And it's like, wait a minute, So it's we're kind of in a bubble a little bit because we're not looked at as threatening or anything like that. And I think all of that comes from you laying the groundwork and just being transparent and talking to the community on what exactly is you're there for, what you're there to do. And I think all of that starts from there.
Thank you, Pete. And I think that goes back to what you mentioned about hiring people who are familiar with the community that you're actually working in. So nice. How about you, Joanna? Safety. I mean, it's a little bit different than being in an urban setting. You potentially could be, in the middle of a forest.
Right. Yeah. So I can never think of one time that I ever felt like I was scared. And I've been doing this for a while. We typically go out in twos. That was policy until we had a relationship with the clients and that we felt safe with them. So I've never felt scared or intimidated. I've been out solo at campsites myself, and much like Pete was saying, we're brought into that bubble. So I many times had my clients looking out for me if I was out solo, just in case if there was somebody that was off their meds or something like that. So I was never, I never felt scared or anything. Yeah.
Working in that team really does help, doesn't it?
It does,
So,
yeah.
Louise, can you speak to that a little bit out in the field, please?
Yeah, I'm happy to. We did have some scary things happen in our study, and really had to beef up some of the expectations about maybe if people were going to go to a neighborhood that they were not familiar with, to go ride through the neighborhood and check it out and do that first. And then always have someone with you and call and let the PI know if there were any concerns. So yeah, and I think when we started, many of the peers were able to transport participants in their personal vehicles. And through the course of the study, I think that all of the organizations that they worked for decided that was not a good idea, and they were not able to do that. We didn't have drivers, Pete, so that would have been helpful, but we did not. But so I think just based on experience, we got more cautious as the study went along.
Excellent, thank you.
And
so we're going to move. We're going to go ahead.
Can I just ask Todd, given that you were in the rural setting, did you have anything to add other than what Joanna already shared?
Just that these peers were really part of the community. They weren't going into an unknown space. This was their community, and there was a lot of trust there.
Thank you.
We're going to go ahead and move forward to the challenges, and looking to the future here. And these 3 projects really provided us an opportunity to really evaluate some of the procedures and the processes, and hopefully can inform us when we're developing future projects that work with peers. And so I'm going to ask, Todd and Kelly and Steve, based upon your collective experiences in working with these projects that you've directed, what sort of recommendations would you have in terms of helping or having peers help to develop the research questions and the interventions? Let's start with you, Steve.
So you know what I'm going to say, Al, and you've heard me say too many degree people here to actually write a paper. So we need to actually get the peers involved early and often, and we need to pay them for that. It's not like we need to have them be just sitting around writing or doing these sorts of things. I know in HPT 1094 we just had a writers workshop, and we are discussing how we are going to want to solicit and invest in the peers who've been out there doing this work to come together to learn how to write a paper, to maybe position their own paper, not just be someone who does a Me Too on a long author line on an outcome paper. So I think it requires us to sit back and rethink what it is about we want to say, and then shut up and let the peers have the word.
Very good. Thank you, Steve. Kelly or Todd?
We're integrating the peers into our national presentations. The papers we're just sort of starting to get a little bit of experience with, and they typically read the draft and provide comment, but it's in the context of the research question itself grew out of these peer conversations. So it's
excellent,
really part of it.
Thank you. Kelly, anything to add?
I agree. I think, the papers are nice. Like Steve said, you don't want to be just another author, but I think the peers have been foundational in the research questions we're asking. And in our study, we're kind of asking them all along the way, check in, what are we doing right by this here? Is this, when a peer reads this paper, is this going to feel like we're representing the field in the way that you all want to go? Outside of the science of it, but just kind of like the philosophy and the questions that we're asking. And then I think some of the things that are easier to present, like posters, those are fun to present, or being on a panel. So Shardina did a great job on the panel, and that was a great opportunity. So looking for those opportunities that are a little bit more spontaneous, I think are great. And then we've been working, like Louise and Tim have worked with some of our peers and me with different venues, like maybe an addiction magazine. So, some of the peers don't want to publish in a scientific journal, but an addiction magazine is something they're really interested in, or maybe doing a podcast And so dissemination in those ways and supporting the peers and kind of where they see their career going, I think has been really, so keeping an open mind and being creative.
Excellent. Thank you. Steve, you have your hand up.
Yeah, I just wanted to add that a good example of peer-led paper writing is Katie Simon's methadone manifesto that's in the American Journal of Public Health. So we don't have to go to magazines. We can actually go to peer-reviewed, high-impact media because the peers, we may not agree with what they say, but letting their voice out in the field is really important. And Katie's wonderful, and if you read her manifesto, and I encourage you to. It's like it's so fresh.
Nice, thank you. So many of us who've worked on grants for a period of time get that it's soft money and that there's uncertainty in continued employment. Todd, you'd mentioned about engaging your peers as research assistants or research associates. Can you talk a little bit more about strategies to help peers sort of move further into research or to help them sort of obtain employment in a greater community following the research participation?
Yeah, absolutely. 3 points. First, we had very transparent conversations a year and a half or so in advance of when we knew the grant was ending, and committed to working with the peers to find employment after that. So the second point is we were actually quite successful. A bunch of us wrote a lot of letters of recommendation. The peers all know that they can list me as a reference for any job, anytime. And then in terms of actual research trajectories, some of our peers have chosen to go on. One is exploring SOCRA training and wants to commit to a career as a research coordinator. So we're facilitating more exposure to those SOCRA training classes.
Excellent, thank you. So I have a question for those peers who are in attendance here. And what was the main challenge that you experienced as a peer working in research? And how was this challenge addressed? And what I'd like you to do is to enter your response in the Q&A. And let's see, can I put that, Kayla, can I put that in the chat for everybody to see?
Yes, you can. Just change the drop down to everyone.
Okay, I'm going to go ahead and do that right now. And then as I do this, I'm going to turn this over to Kelly. Thank you. I really appreciate the panel members, your thoughtful discussion. Tim.
We have a couple more minutes. So sorry, hold on one second, Kelly. I appreciate it. I just wanted to ask a question. There was a question about gender concerns. Men working with women, vice versa. What about trans folk? Can anyone answer or address that at all? How were gender issues addressed in this job? Male peers support women IDU. Is there any risk of gender violence? Peers for transgender?
I can say for our study that we're accepting of everybody regardless. So it doesn't matter, male, female. We never really dealt with that. We had many people that are transgender throughout, we work with on a regular basis. I guess that's like the highlight of being employed at the HIV Alliance and with the study was because of the diversity and the empathy there. So
thank you,
there was a lot of education in regards to transgender as well throughout.
Thank you.
I'll mention that in pilot, there were a lot of instances where it was a male peer with a female participant or vice versa, but there were a few times, not very many, but a few, where we did make a switch. because of a particular issue that came up, and we could change to a different peer if that seemed like the right thing to do. So we did do that a few times.
Thank you. Pete, anything you want to add to that?
Yeah, this is pretty much why I really push diversity amongst as far as what you hire and a team approach, just to allow the participant to, if they do feel a little closer to a peer that's not their actual assigned peer, that relationship could be allowed to grow. So that's where I think like it's important to have some diversity as far as who you hire as the navigators in general.
Thank you. And I know that Kelly, sorry, I'm going to shut up in 1 second, but Al had asked for any peers who are on this webinar right now to type in the Q&A what was the main challenge working in research for you? And briefly, how was this challenge addressed? We won't be able to read all of them, but we would like to capture this information and forward it to people interested. Thank you. Go ahead, Kelly.
Okay. Well, thank you, everybody, for a lively discussion. I'll just spend a minute closing us up and summarizing what was shared today. So what the takeaways that I saw for today were that peers are stigma busters. So we heard from Dr. Humphreys that they come in when others won't, and it's been across the world and over decades. Todd shared with us that peers are the trusted voices among those who are not engaged in traditional care. Dr. Humphreys shared that the peers over decades have profoundly affected this field by caring and investing in those with substance use disorders. And they go out to the people with substance use disorders, into the community, we've heard, into the homes, into encampments, and into rural areas. So peers as frontline essential workers have needs such as supervision. We've heard that from Tim and Louise and the others. Support. We heard from Peter that it's okay to make mistakes, and it's okay for the team to kind of have that kind of philosophy. It's important for self-care. There's importance for peers for growth opportunities, cross-training opportunities, and job opportunities after research, whether that's within research or out. The importance of the team, we heard again from Peter. And that you're not alone. Importance of safety, both physical and recovery, and we're doing an overall good job with that. But we heard from Joanna and Peter on that front as well. And all of these things help prevent burnout for these peers that we have so much value in on our team. So we have to invest in those areas. From the research logistics, some of the takeaways are that there is ongoing need for training regarding research protocol and documentation, and that's for all of us, and the peers included. Peter had a good quote: peers are not robots, so some flexibility is key. We can manualize it to an extent, but we have to give peers flexibility. That's kind of, we talk about that in pilot, that's kind of the mojo, is that they can kind of react in real time to what's going on. Dr. Humphreys said, somebody who has been there has something to offer, but how do we measure what they're offering? And so what are they offering? How do we measure that? What questions about dose and fidelity, which we're kind of making some headway here with these studies. How do we replicate that? And then how do you document in the field? So just some logistical challenges, but I think there's a lot to think about here and a lot to act upon as we move forward in continuing to do research, continuing to involve peers from day one in our research design, and in working with peers with research. So we thank you all for attending. We thank the presenters. We thank all the attendees, and we will finish up for today. So thank you.
And that concludes today's presentation. You may now disconnect.
Thank you, everyone.